This week we're going to talk about death and dying and the ethics of that and medical ethics. And this is a system problem. So one of the things to keep in mind when you're doing the readings is what is it about the whole system that's a problem or that's an issue, because it's sort of like a system failure on each level. First of all, look at what the actors are doing. So look at the doctors, the insurance companies, the patients, primary care physicians, specialist doctors, hospitals, people who work in the hospitals, families before this event happens. All of these things are sort of doing a domino effect of everybody in denial, and it makes for an expensive outcome and a negative outcome, and for people not having autonomy, and people not being able to control their destinies, and people not having enough information to make informed consent. And you can't change one part of it, you have to change all the parts of it. One of the things I want you to think about in your cases that you talk about and in your final paper is how are you as administrators going to change things and impact the system so we get these ethical outcomes of autonomy, informed consent, privacy, the right to make our own decisions, justice, all of those things, if we don't change all the component parts. And what do? You can't just go training. You've got to go, what kind of training? Who do you train? How do you keep that process moving along? Because we have more and more technology that make death further and further away and make it seem like there's always a better option and that we can have these life-saving events. And that's not necessarily what you're going to see in the readings. What you're going to see in the readings is lots of money, lots of pain, no informed consent, no information, pressure from family. Doctors won't even tell you the real outcome and consequences. People giving you treatment that's $10,000, some of which is their profit. That's something the articles don't talk about. So they profit off of all of this, but the patient doesn't. The patient suffers. The patient doesn't have a quality of life. The patient doesn't have a just end. These are all things you have to keep in mind. And if you want to look bigger picture, if we're spending all this money on people at the end, then that means we don't have money for people all during life or to do prevention. So, we're not going to print more money. There's a limited amount of resources and money. So if it goes towards everyone at the end and it has these catastrophic events, then we're taking money away from the front end or from other things that could happen. I want you to pay attention to how all the actors see these issues, how all the actors are behaving in these issues, and what may or may not be right or wrong with that, especially in relationship to those concepts we talk about in ethics. Pay very, very close attention to the Aetna experiment, where they sort of said, okay, we won't make you not be able to have the treatment, but we're going to do the hospice stuff in addition to the treatment to sort of get that buy-in. And then they had these amazing results. You'll see that in the Letting Go article. Also, one of the things to keep in mind is, we say we're going to train people. Okay, how do you train people? What do you do? And one of the things you'll see again in the Letting Go article is words matter, and they're not necessarily the words that each of these actors is trained to use. So you saw the insurance company change. You saw doctors thinking about differently how they say and do, engaging with patients and with the family. Pay attention to what you think is the breaking point. That was a really interesting part, I thought, of this, that there's a point where you need to sort of do these interventions and it's not all at once. So how can we build a system where there are things that intervene to change the outcomes further out, even if you don't know when that further out will be, so that when we get there, we have a different mindset. Actors have responded differently all along. Not, oh, we're just going to change everything at the end. That's not going to work, as you see from a lot of the articles. Also, what are the incentives for everybody? I've talked about how with the specialists, they get money for providing treatment. They don't get money for providing education, for educating the family about why the next best thing is really not the next best thing. So you have to keep in mind, what are people's incentives? Insurance will pay for treatment. Some of them won't pay for hospice. Some of them won't pay for the extra components of hospice. How do we train people if we say, oh, we're going to give you hospice? You have to train from intervention to comfort care, and that's a whole different mindset for everyone involved. And it's a different reimbursement. So again, the hospitals make money by you being in the hospital. If we're not going to make you in the hospital and you're going to be in hospice, they can see this as a money-losing venture. The family sees you as not having access to care and that your doctors don't care. How do we change that mindset? We can't just do it at the end. We have to do it in the very beginning of how you think about your options, how you use informed consent. Some of this is a problem that we're not just seeing in Death and Dying. We're seeing it in a problem of people think that if I don't do these things now, it'll be fine. We'll have a magic pill later. But in reality, a lot of things you can do to prevent certain things at the end, there's no incentive for you to do that. The doctor doesn't get paid to keep you healthy. You don't use the information or understand the information you have access to, so we get these sort of negative outcomes and these unrealistic expectations. So again, you have to think about how each actor's thinking, how we change and intervene for each actor in relationship, again, to those sort of scaffolding of those concepts that we talk about every week. How do we get informed consent? Well, we have to make sure people understand information. And is it the whole patient? So it's got to include the family, because we saw in a lot of cases the family's like, oh no, don't do this, do that. And they're putting pressure on that patient. And that's not a real way for someone to have informed consent and have autonomy if their family is pressuring them to do things. We never sort of ask people what they want. We never help them get to what they want. Sometimes we're surprised by what they want, maybe because we never ask. That's another thing you need to think about. How do we listen? How do we make sure that these conversations happen and not just a one-off, but throughout the entire process? Shouldn't your doctor know who you are to begin with? That's not happening. Should there be an incentive not to treat someone if it's going to do negative consequences to them? Do no harm. Harm, as you saw from a lot of these cases, was really bad, often worse than the disease itself, and it took them away from the things that they wanted to spend time with, like their children or their family, or watching baseball or football or whatever, right? But again, that's based on what they want, not what you want for them. And I think a lot of we as administrators have to sort of remind people that the individual patient gets to say what they want. We are a partner, and we want to make sure that they have more options, but not just one option. And how do we bring that about? How do we change all the actors? How do we change the dialogue? How do we change this process? And how do we get more just outcomes for the patient, for the hospital, for the insurance company, for the family? And how do we get to these ethical goals that we want? Because that is part of our mission, not just making you better, but also taking you through the entire entity of your life to have a good ending, not a highly medicated, not the way you want ending that's super expensive and doesn't allow you to do the things that you think as a patient add quality to your life. So I really want you to think about these things when you read. Keep notes about what you see that's innovative. What are these incentives? What are the language we need to use? How do we engage the family? Because sometimes they're a problem. How do we connect with the patients? Can we do this before a crisis event? How do we do all of this all at once and change the whole system?